Hyponatremia is common in critically ill patients, both as part of the presenting constellation of symptoms and as a consequence of their ICU course. A thorough understanding of its causes, effects, and management are essential to anyone practicing in this field. Hyponatremia is defined as a serum sodium concentration less than 135 millimoles per litre. Sodium is the most common extracellular cation. Its concentration in the extracellular fluid is tightly controlled to values between 135 and 145 milliequivalents per litre. It is regulated not by controlling the absolute quantity of sodium, but by regulating the volume of water it is dissolved in. Water balance is largely achieved by the release of antidiuretic hormone, otherwise known as arginine vasopressin. Osmoreceptors in the brain respond to high plasma osmolality by releasing ADH, which regulates water balance by stimulating production of aquaporin. This in turn allows water to be reabsorbed from the distal convoluted tubules and collecting ducts of the kidney. The driver for water reabsorption is the development of a very high osmolality in the interstitial fluid of the renal medulla, generated by the ion pumps of the loop of Henle. When ADH secretion is maximally stimulated, the urine can be concentrated to nearly 1,200 milliosmoles per litre, greatly in excess of the normal plasma osmolality of 285 to 295 milliosmoles per litre. In the presence of plasma hypotonicity, the secretion of antidiuretic hormone is almost completely abolished. This results in the prevention of water reabsorption from the collecting ducts. The urine in this circumstance may have an osmolality as low as 50 milliosmoles per litre. In this way, free water is excreted and plasma tonicity rises. Antidiuretic hormone is also released in response to hypovolemia. This is an extremely powerful stimulus and easily outweighs the suppressive effects on antidiuretic hormone secretion imposed by reduced plasma tonicity. The release of natriuretic peptides in response to hypovolemia results in natriuresis. This results in the reduction in tonicity of the plasma and consequent water loss. As total body sodium levels decrease, water is lost to maintain concentrations in the normal range. This leads to a reduction of the extracellular fluid space, but the serum sodium concentration is largely kept in the normal range. Because of these mechanisms, hyponatremia usually reflects an issue with total body water regulation rather than total body sodium levels. Disruption of these important regulatory mechanisms is the driver for acute hyponatremia. The pathology of hyponatremia is probably related to the impact of serum tonicity, which results in fluid shifts into various compartments, but most notably the brain. The predominant effects of hyponatremia are related to central nervous system dysfunction arising from cerebral edema. Lethargy, nausea, disorientation and headache are often followed by seizures and coma. Ultimately, raised intracranial pressure and herniation can result. The rate at which sodium levels fall is also important. When subjected to hypotonicity over the long term, neurons adapt to the increase in cellular water by extruding osmogenic particles that reduce intracellular osmolality, limiting cerebral edema. These osmotically active substances include electrolytes like sodium and potassium, and are later followed by amino acids such as glutamate and taurine, and carbohydrates such as inositol. This is a double-edged sword, however. The reduced intracellular osmolality means that when extracellular sodium is corrected, water exits the cells and the cell becomes relatively dehydrated. The rate of correction of the sodium levels, therefore, is critical to allow for adaptation. Due to this adaptation, patients with chronic hyponatremia may be asymptomatic. The absence of an altered conscious state in concert with a sodium concentration less than 120 millimoles per litre usually implies a chronic course. Samples taken from limbs where IV fluids are being run can reflect the dilution of blood with that fluid. This is usually obvious from the associated biochemistry, which is similarly disturbed. These two disorders can cause a laboratory miscalculation of the serum sodium. When analyzers use flame photometry or other indirect measurements of sodium concentration, the sample is spun down and protein and lipid content is discarded. The value obtained from the remaining sample is then reported as if it is rediluted in the original volume, but assumes that protein and lipid are normal. When they are abnormally high, this assumed volume is much bigger, and the resultant sodium concentration is artificially reported as low. These conditions are referred to as pseudo-hyponatremia and are not of clinical consequence. Modern analyzers test samples differently using an ion-specific electrode, and it is uncommon to face this conundrum in clinical practice. Samples taken from a blood gas analyzer are not affected and reflect the true value. The osmolality of the blood under normal circumstances can be approximated by the formula 2 times the sodium concentration plus glucose plus urea. Unlike sodium and glucose, urea is freely able to cross cell membranes and does not govern water movement across compartments. Glucose, however, when elevated, will raise the tonicity of the extracellular compartment but not the intracellular. Water travels down its concentration gradient to equalise this discrepancy. Consequently, serum sodium concentrations fall, but the osmolality is still high. This is sometimes termed hyperosmotic hyponatremia. An idea of the true sodium level can be derived from the corrected sodium calculation. Many of these calculators exist, but the simplest may be to add 1 milliequivalent per litre to the sodium concentration for every 3 millimoles per litre rise in glucose above the normal range. This formula may slightly underestimate the true sodium value. Note, this is the sodium concentration that would be achieved if the hypoglycemia was reversed. A similar circumstance may result from the presence of other osmotically active agents such as glycine, mannitol, and toxic alcohols such as methanol and ethylene glycol. Glycine is sometimes implicated in the post-TERP syndrome due to the irrigation with glycine-rich fluids, which are absorbed by the highly vascular prostate gland. However, because tonicity is normal or even high, it is unlikely that the apparent hyponatremia has any impact, and the toxicity is more likely to be due to the effects of the glycine itself. Antidiuretic hormone is released as a physiological response to hypovolemia. The retention of fluid results in expansion of the total body water, which will assist in restoring circulating volume. As mentioned previously, this occurs even in the presence of hypotonicity. Hypovolemia also stimulates renin release, which contributes to salt retention, which reduces the impact on serum sodium concentrations. However, if solute intake is also reduced, hyponatremia may rapidly develop. Thirst stimulation often leads to water intake, exacerbating this problem. Even when total body fluid and electrolyte levels are high, Reduced apparent blood volume will stimulate antidiuretic hormone release. This is seen in chronic heart failure, cirrhosis, and in some other protein deficiency states. A number of stimuli can result in the inappropriate release of antidiuretic hormone in a syndrome known as SIADH. An extremely common setting in which SIADH can occur is post-surgery. A number of factors can contribute to the ADH secretion in this context, including pain, narcotic medications, and relative volume depletion. Urine output falls due to the activity of ADH, and patients are often prescribed unnecessary increased IV fluids as a result. Free water in the form of hypotonic fluids for either maintenance or resuscitation cannot be excreted, and hyponatremia results. Even normal saline can potentially cause hyponatremia if urine diluting ability is compromised. Fatalities have been reported, particularly in young females. Under normal circumstances, the kidney very efficiently dilutes the urine by the time it reaches the distal convoluted tubule. In the absence of ADH, this urine is excreted unchanged and free water clearance is maximal. When the urine diluting ability is compromised, any additional free water that is ingested cannot efficiently be excreted, and hyponatremia will result. In these cases, the osmolality of the urine is almost always greater than 100 milliosmoles per litre. Causes of reduced concentrating ability include disorders of the tubules such as sickle cell anemia, chronic interstitial nephritis, chronic renal disease, and non-steroidal anti-inflammatory abuse. Interestingly, thiazide diuretics also impair this mechanism by preventing reabsorption of salts from the distal convoluted tubule. This results in more concentrated urine reaching the collecting duct, so less free water can be excreted. Loop diuretics also reduce the ability of the kidney to produce dilute urine, but they also reduce the osmolality development in the medullary interstitium, the factor that drives water reuptake when aquaporin channels are present. As such, water retention is less than would be expected. Consequently, hyponatremia is infrequently associated with loop diuretics, and often with thiazides. However, ingestion of large water loads or reduction in solute intake in these circumstances can cause hyponatremia in loop diuretics too. Other diuretics, including indapamide, have been implicated. A similar circumstance is encountered when very little solute is ingested. Reduced salt and protein intake, the so-called tea and toast diet, or beer potomania, where alcoholics consume little but low solute beer, are but two examples. Babies fed dilute milk products or water is another cause, compounded by the markedly reduced ability to excrete water of the infant kidney. Hypothyroidism and hypoadrenalism affect the ability to excrete water too by various mechanisms. Psychogenic polydipsia is a condition that requires an enormous amount of water to be consumed, in excess of 15 litres per day. This overwhelms the kidney's ability to excrete free water. Alternatively, additional factors such as reduced solute intake and concomitant thiazide treatment may lower the volume of fluid required as the diluting ability of the kidney is reduced. Exertional hyponatremia is quite common in endurance athletes, with up to 13% of marathon runners demonstrating low sodium concentrations in some studies. Interestingly, this is often associated with an increase in body weight, suggesting retention of hypoosmolar fluids during the race. It is thought that athletes consume significantly more free water than is lost through the sweat. This often stays in the gut during the peak performance and is rapidly reabsorbed once the gut function returns at the end of the race. This, combined with exercise-induced release of ADH, leads to massive free water retention. Concomitant use of non-steroidal anti-inflammatory drugs may also play a role. A number of street drugs, such as ecstasy, have been associated with increased water intake and dysregulation of water balance, resulting in hyponatremia. A similar effect is sometimes seen with serotonin-specific reuptake inhibitors. In all of these conditions, it is expected that the urine would be maximally dilute, with a urine osmolality of less than 100 milliosmoles per litre. Conjecture remains regarding this very uncommon syndrome. Cerebral salt wasting is associated with low plasma osmolality, a high urine osmolality, and a urine sodium concentration greater than 20 millimoles per litre. It can be differentiated from SIADH as the patient demonstrates evidence of volume depletion. The contention has been that for unclear reasons, the neurological injury promotes renal sodium loss that results in concomitant hypovolemia. Replacement of sodium and plasma volume expanders in association with mineralocorticoid therapy has been effective. The classic syndrome of inappropriate ADH secretion has been defined as follows: hypotonic hyponatremia, urine osmolality greater than 100 to 150 milliosmoles per litre, demonstrating that the urine is not maximally dilute, urinary sodium concentration greater than 20 millimoles per litre, which reflects a normal renal perfusion, absence of other identified causes such as thyroid dysfunction, cortisol deficiency, heart dysfunction, liver disease and renal disease, euvolemia, and normal potassium and acid-base balance. SIADH also is known to resolve with water restriction and is exacerbated by water administration, though this is rarely tested in practice. There are many causes for SIADH, which can be seen in this table. The use of exogenous ADH for medical conditions can be an unusual cause of SIADH. In these circumstances, it is best to fluid restrict the patient and continue the ADH treatment to avoid very rapid resolution of the hyponatremia. This will be discussed in greater detail later. Many of these criteria must be regarded with some caution, as the presence of other pathology may interfere with their interpretation. For example, some patients mentioned above may not be able to concentrate their urine, while other criteria cannot be interpreted in the presence of diuretic or saline administration. Recently, a theory of the reset osmostat has been suggested. In this theory, the osmotic values at which the ADH mechanism is triggered are lower than normal, but are still intact below this value. This is thought to explain hyponatremia in the context of pregnancy, quadriplegia, psychosis, tuberculosis, chronic malnutrition, and a number of other causes. It should be suspected when mild hyponatremia appears static over days to weeks. In theory, these patients behave similarly to patients with normal osmoreceptor function in response to water excess and deprivation, but at a lower sodium value. Attempts to fluid restrict may result in marked thirst even at sodium concentrations less than 130, and the administration of water is readily excreted. It seems this is important to recognise, as it is largely benign and can be essentially asymptomatic. Treatment should focus on the underlying cause. Plasma osmolality helps differentiate hypotonic hyponatremia from hyper or normotonic causes as outlined previously. A gap between calculated osmolality and that measured by the freezing point depression technique may indicate the presence of another osmotically active agent such as mannitol, glucose or toxic alcohols. A serum glucose should also be taken. Urine osmolality and electrolytes should be assessed. This will indicate whether or not the kidney retains the ability to maximally excrete dilute urine. If it does, excessive intake of water is the likely cause. Urine sodium should be analysed. If the cause is due to hypovolemia, either apparent or real, urinary sodium is low, usually less than 20 millimoles per litre, due to the aldosterone effect resulting in maximal sodium reabsorption. A urine sodium greater than 40 millimoles per litre favours the diagnosis of SIADH or salt wasting. As with any patient, protection of the airway, maintenance of oxygenation and ventilation, and support for the circulation are paramount. The most important decision to make in the management of severe hyponatremia is whether or not the patient has evidence of hyponatremic encephalopathy. Asymptomatic hyponatremia should be managed conservatively, while highly active treatment is required for those with neurological symptoms. The second key consideration is to recognise that when reversible factors that lead to hyponatremia are reversed, correction of the hyponatremia can be unpredictable and very fast. The importance of this is discussed in the next section, and an awareness that this may occur is very important in the prescription of therapy. Rapid correction of hyponatremia has been implicated as a risk factor for the development of osmotic demyelination. Once known as the central pontine myelinolysis syndrome, it is now known that this may affect many sites in the central nervous system. It is often severe and debilitating. It is thought that when central neurons have adapted to hyponatremia, as discussed previously, the rapid correction of extracellular tonicity results in the osmotic gradient out of the cells, resulting in cellular dehydration. This may lead to pathological responses resulting in demyelination. Osmotic demyelination usually begins at least 2 days after the initial correction of sodium and sometimes several weeks later. Classic changes include altered mental state, fatigue, failure to respond as expected, dysarthria, dysphagia, sensory change, paresis, and seizures. Certain groups seem to be protected, but premenopausal women, children, and hypoxic patients appear at most risk. The test of choice is MRI, although changes may develop slowly and initial scans may be misleading. Both the duration of hyponatremia and the rate of correction have been identified as potential risk factors. Risk is highest in those whose sodium concentrations rise greater than 20 millimoles per litre in the first day, and those who overcorrect beyond 140 millimoles per litre. As such, it has been recommended that correction of serum sodium concentrations be limited. Commonly suggested values include a rate of no more than 0.5 mils per hour and a total no greater than 12 millimoles per 24 hours and 18 millimoles over 48 hours. Some authors recommend a more circumspect approach, advocating less than 8 millimoles rise in the first 24 hours. In animal studies, under these conditions, demyelination is rare. In some circumstances, sodium concentration may increase more rapidly than expected. This often occurs where the stimulus for the hyponatremia is rapidly reversed, such as in hypovolemia, resolution of diabetic ketoacidosis and hypoglycemia, or cessation of exogenous DDAVP. In this case, the kidney responds by aggressively clearing free water. A brisk rise in urine output will suggest this, and is confirmed by measuring the urinary sodium and potassium. If added together, they are significantly less than the sum of the plasma sodium and potassium. A significant free water clearance is occurring. In these circumstances, careful titration of therapy is required with frequent estimations of serum sodium. Free water may even be necessary, such as in the form of 5% dextrose, or even the addition of DDAVP. This is supported by evidence in animals, but little is available in humans. Experienced assistance is required in these situations. As a general rule, the rate of rise should be tailored to the patient, and the slowest rate of correction that the clinical situation allows should be employed. The adage, slow down, slow up, fast down, fast up, seems appropriate. Fluid administration with an isotonic solution such as normal saline is reasonable in the context where there is true fluid depletion. Additionally, this may apply in patients who have been over-diuresed, central salt wasting syndromes, or those with cortisol deficiency. Normal saline causes a rise in serum sodium, but its direct contribution to the serum concentration is relatively insignificant. A litre of normal saline would only be expected to raise the serum sodium in the order of 1 to 2 millimoles per litre. By contrast, correction of the volume state will switch off ADH secretion, resulting in a fairly rapid rise in serum sodium concentrations, which should be monitored very carefully. In fact, normal saline may actually worsen hyponatremia if the kidney's ability to dilute urine is maximally impaired, such as in severe SIADH. Volume replacement in those with apparent hypovolemia, such as in advanced cirrhosis or heart failure, may temporarily improve the circulation but will ultimately worsen edema. Fluid restriction as tolerated and efforts to improve the underlying condition if possible are usually more appropriate. In situations where hyponatremia is related to fluid intake that outweighs the ability of the kidney to clear it, such as in psychogenic polydipsia, fluid restriction is a reasonable and effective approach. Again, where treatment of these causes is instigated, the correction of the sodium level may well be very rapid and careful monitoring is required. Fluid restriction is also very useful in patients with SIADH. Combining fluid restriction with furosemide is appropriate for free water clearance in patients with SIADH. Furosemide generates a hypotonic urine similar in constitution to a 0.4% normal saline, allowing free water clearance to occur. Note that fluid restriction alone is not appropriate for patients who have evidence of neurological symptoms. Patients with severe symptoms such as fitting, severe headache and coma may require specific therapy with concentrated sodium solutions. The pathology causing these symptoms is raised intracranial pressure related to the progressive cerebral edema. Alteration of the intra to extracellular osmotic gradient such that water escapes the cells can be achieved by administering hypotonic saline. It has been estimated that the volume change to relieve symptoms can be achieved with as little as 3 millimoles per litre increase in the extracellular fluid sodium concentration. Since sodium is distributed in the extracellular space, the calculation of dose can be made as follows. Consider a 64 kilogram, 40-year-old woman with a sodium of 110. Total body water can be calculated from the following table, in this case about 32 litres. Extracellular fluid forms approximately 1/3 of this volume, approximately 11 litres. To raise the extracellular fluid's sodium concentration by 3 millimoles per litre, we need to add 3 millimoles per litre of extracellular fluid, or around 33 millimoles of sodium. The sodium content of some commonly available saline solutions is shown here. Thus, we would give her 66 mils of 3%, 26.5 mils of 7.5%, or 11 mils of 20%, for instance. Because the administration of large amounts of sodium chloride is associated with a metabolic acidosis, intermittent use of sodium bicarbonate solutions may also be of value. Subsequently, or for less severe patients, the serum sodium may be increased at rates of 1 to 2 millimoles per litre for the first couple of hours if severe symptoms are present. This can be reduced after the symptoms resolve. The same calculation can be used to calculate the quantity required to raise the serum sodium to a target value. This quantity is then administered over a defined time period to achieve the desired rate of change. For example, after this initial bolus therapy, we may wish to increase the patient's sodium from 115 to 122 to maintain the change of less than 12 millimoles per litre over the first 24 hours. To do this, she will require 77 millimoles of sodium, 7 millimoles for each of the 11 litres of extracellular fluid. This equates to 154 mils of 3% sodium over a 24-hour period, a rate of approximately 6.5 mils per hour. Of course, this is an estimate only, and frequent sodium estimations, perhaps 2 hourlies to begin with, are required. For less unwell patients, and after the resolution of severe symptoms, slow replacement as detailed previously is recommended. A total rise of no more than 12 millimoles per litre in the first 24 hours and 18 millimoles per litre in the first 48 hours is recommended. The response to hypertonic saline administration in a patient with SIADH is far less predictable. Hypovolemia triggers salt wasting mechanisms that excrete the administered saline, but an osmotic diuresis results, which increases the excretion of free water. The extent to which this occurs is determined by the concentrating ability of the kidney at the time, which is, of course, dependent on the degree of SIADH. Interestingly, administration of potassium has effects on sodium concentrations as well. Potassium is the major intracellular cation, and since water moves freely between the extracellular and intracellular spaces, the tonicity of these compartments must be the same. As K is taken up by cells after administration, the osmotic gradient is developed that drives water into the cells, raising the sodium concentration in the extracellular space. This effect is mild to moderate and must be considered when calculating the expected change in sodium in response to an administered solution. An example of a calculator for this is shown here. Potassium replacement is often necessary, but caution should be exercised if the patient has signs of cerebral edema. This drug, like lithium, reduces the responsiveness of the distal collecting system to ADH, which results in additional free water clearance. In practice, it's rarely used in the acute situation and is sometimes employed in patients who do not respond or are intolerant of therapy. In this video, we have highlighted the importance of hyponatremia in ICU practice. A number of causes exist, and a thorough understanding of the pathological and physiological mechanisms are necessary. We have also covered the basic management of these complex problems. If you enjoyed this presentation, why not visit our websites at www.crit-iq.com and www.crit-nurse.com. Critique is a leading provider of online educational resources for critical care clinicians. No matter what your level of experience or training, Critique has something for you. Our regularly updated journal club and podcast interviews will help to keep you up to date with the latest news, while our Echo database and modules teach you new skills. We even have a series of new apps to help you on the go. You can even join our open access blog and have your say on current topics. Critique, critical for life.